Today, I will be discussing to you the different diseases of the aorta. So the aorta is the largest vessel in the body, which serves as a conduit through which blood ejected from the left ventricle is delivered to the systemic arterial bed. In adults, its diameter is approximately 3 centimeters at its origin, and in the ascending portion, 2.5 centimeters in the descending portion in the thorax, and 1.8 to 2 centimeters in the abdomen. The aortic wall has 3 layers, namely the tunica intima, the tunica media, the tunica adventitia. The tunica intima is the innermost layer, which is composed of the endothelium, subendothelial connective tissue, and an internal elastic lamina. The second layer, which is the tunica media, is composed of smooth muscle cells and extracellular matrix. The outermost layer, which is the tunica adventitia, is composed primarily of connective tissue enclosing the vasa vasorum as well as the nervi vascularis. Several congenital anomalies are associated with the diseases of the aorta. There may be a ring around the aorta which might present as dysphagia, stridor, and cough. Anomalies associated with symptoms includes double aortic arch, origin of the right subclavian artery distal to the left subclavian artery, and a right-sided aortic arch with an aberrant left subclavian artery. Most congenital anomalies of the aorta do not cause symptoms and are only detected during catheter-based procedures. The diagnosis is typically confirmed by requesting a computed tomographic or magnetic resonance angiography. Treatment is surgery to treat symptomatic anomalies. The first disease of the aorta that we are going to discuss is the aortic aneurysm. Aneurysm refers to pathologic dilatation of a segment of a blood vessel. It has 2 types. The first type is true aneurysm. In true aneurysm, it involves all the 3 layers of the vessel wall. While a pseudoaneurysm or a false aneurysm, only the intimal and medial layers are disrupted, and the dilated segment of the aorta is lined by the adventitia only, and sometimes by a perivascular clot. Aneurysm is also classified according to its gross appearance, namely fusiform and saccular aneurysm. Fusiform aneurysm affects the entire circumference of a segment of the vessel, resulting in a diffusely dilated artery, while a saccular aneurysm involves only a portion of the circumference, which results in an outpouching of the vessel wall. Aneurysm, according to location, is classified into 3: abdominal aortic aneurysm, thoracic aortic aneurysm, and a combination of 2, which is referred to as the thoraco-abdominal aortic aneurysm. This picture shows to us what a normal vessel looks like. So it has 3 layers from the outermost tunica adventitia to the innermost tunica intima. And letter B shows to us a picture of a true saccular aneurysm. You can see all the 3 layers are involved, and the outpouching is only on one side of the aortic wall. The third picture is a picture of a true aneurysm fusiform type. All the three layers are again involved, but at this time, the whole circumference of the aortic wall is involved. Letter D is an example of a false aneurysm, wherein only the tunica adventitia is involved, forming an outpouching, and there is an extravasation of the blood from the lumen of the aorta, causing hematoma in the outpouching. This is very prone to rupture, which necessitates emergency surgery. And letter E is an example of an aortic dissection wherein it shows that there is a tear in the tunica intima. There are several etiologies of aortic aneurysm. These are conditions that cause degradation or abnormal production of the structural components of the aortic wall. So the two structural components of the aortic wall are the elastin and collagen. Etiologies may be broadly classified as to degenerative disorders, genetic or developmental diseases, vasculitis, infection, and trauma. Histopathology demonstrates destruction of elastin and collagen. There is decreased vascular smooth muscle. There is ingrowth of new blood vessels and inflammation. This table shows to us the different etiologies and associated factors of aortic aneurysm. So it could be degenerative, which might be secondary to aging. It could also be secondary to cigarette smoking, hypercholesterolemia, hypertension, and atherosclerosis. Among these causes of degenerative aortic aneurysm, the most common is atherosclerosis. Going to the genetic or developmental etiologies, several has been mentioned, such as Marfan's syndrome, Loeys-Dietz syndrome, Ehlers-Danlos syndrome type 4, Turner syndrome, and familial causes. Also, bicuspid aortic valve can cause aortic aneurysm. Chronic aortic dissection can also cause aortic aneurysm. Inflammation of the aorta, infection, and trauma are all possible etiologies of aortic aneurysm. So let's discuss them one by one. For degenerative aortic aneurysm, these are the mentioned causes, and the most common cause of which is atherosclerosis. The most common pathology associated with ascending aortic aneurysm is medial degeneration or cystic medial necrosis. The degeneration of collagen and elastic fibers in the tunica media of the aorta, as well as the loss of medial cells that are replaced by multiple clefts of mucoid material, such as proteoglycans. This is what happens in medial degeneration or cystic medial necrosis. In patients with Marfan's syndrome, Loeys-Dietz syndrome, Ehlers-Danlos syndrome type 4, hypertension, congenital bicuspid aortic valves, and familial thoracic aortic aneurysm syndromes. This is the etiology. For Marfan's syndrome, fibrillin 1 is the most important component of the extracellular microfibrils, which support the architecture of elastic fibers and other connective tissue. For Ehlers-Danlos type 4, it involves the mutation of type 3 procollagen. So always remember, For Marfan syndrome, it is because of the mutation in fibrillin 1 gene, and for Ehlers-Danlos type 4, it's the mutation of the type 3 procollagen. Thoracic aortic aneurysm, the most frequently associated cause of aneurysm of the descending thoracic aorta is atherosclerosis. Most thoracic aortic aneurysms are asymptomatic. However, when there is already compression or erosion of the adjacent tissue by this aneurysm, this will now cause symptoms, which includes chest pain, shortness of breath, cough, hoarseness, and dysphagia. Etiologies for infectious aortic aneurysm can be syphilis, which is 90% located in the ascending aorta or aortic arch. Tuberculous cause, this typically affects the thoracic aorta and result from direct extension of the infection from the hilar lymph nodes or a contiguous abscess, as well as from bacterial seeding. The last infectious cause is mycotic aneurysm. This could be a result of a staphylococcal, streptococcal, salmonella, or other bacterial or fungal infections of the aorta, usually located at the atherosclerotic plaque. Diagnosis of which is established by requesting for chest X-ray, which is the initial test in the diagnosis. You can also request for a transesophageal echocardiography, wherein a probe is advanced into the esophagus for a closer view of the heart as well as the great vessels such as the aorta. So these can now be used to assess the proximal ascending aorta as well as the descending thoracic aorta. You can also request for a contrast-enhanced CT scan, magnetic resonance imaging, and conventional invasive aortography. These tests are sensitive and specific for the assessment of aneurysms of the thoracic aorta and involvement of branch vessels. So on your right is a picture of a chest X-ray of a patient with thoracic aortic aneurysm. As you can see, there is aneurysmal dilatation of the thoracic aorta. On your left, you can see a magnetic resonance angiogram of a patient with a fusiform aneurysm involving the ascending thoracic aorta. So there is involvement of the whole circumference of the ascending thoracic aorta, with the diameter measuring 49.5 millimeters. For the treatment, medical treatment includes beta blockers, which reduce the rate of expansion, angiotensin receptor antagonist, which will control the hypertension, and reported to reduce the rate of aortic dilatation in Marfan syndrome. The definitive treatment is an operative repair with the placement of a prosthetic graft. This is indicated for all symptomatic ascending thoracic aortic aneurysm and for those with no symptoms but the diameter of the thoracic aortic aneurysm is more than 5.5 centimeters. So these are the two indications for operative repair. Let's proceed with abdominal aortic aneurysm. This occurs more frequently in males than in females, with the incidence increasing with age. Most of these aneurysms are located infrarenal, meaning below the level of the renal arteries. The risk of rupture increases proportionally with the size of the aneurysm, meaning the 5-year risk for aneurysm for a less than 5 centimeter diameter is only 1.1 to 2%. But when the diameter exceeds more than 5, the risk of rupture increases to 20 to 40%. Usually, these are asymptomatic, but on routine physical examination, the physician is able to appreciate a palpable, pulsatile, expansile, and non-tender mass in the abdominal region. This could be an incidental finding observed on an abdominal imaging study performed for other reasons. For example, the patient is complaining of an abdominal pain and the physician requested for a whole abdominal ultrasound. Incidentally, an abdominal aortic aneurysm can be seen. So for the diagnosis, it is established by abdominal radiography, which may demonstrate the calcified outline of the aneurysm. About 25 of the aneurysms are not calcified. Therefore, it cannot be visualized by X-ray imaging alone. However, abdominal ultrasound is able to delineate the transverse and longitudinal dimension of the aneurysm. It may also detect the presence of mural thrombus. It is useful for serial documentation of aneurysm size. Therefore, abdominal ultrasound is used as a screening method for men aged 65 to 74 years old, and this is associated with a risk reduction in aneurysm-related death of 42%. You can also request for CT with contrast as well as MRI. This is able to determine the location and the exact size of the aneurysm. Hence, this is used to plan endovascular or open surgical repair. So pre-operatively, either CT scan or MRI is requested for planning. You can also request for contrast aortography. However, this carries a small risk of complications such as bleeding, allergic reaction to the dye, and atheroembolism. These tests may underestimate the diameter of an aneurysm due to mural thrombus. So for the treatment, the definitive treatment is operative repair of the aneurysm, either open repair or an endovascular placement of an aortic stent graft. So this operative repair is indicated only for abdominal aortic aneurysm of any size that is rapidly expanding and is symptomatic. That's the first indication for operative repair. Another indication to send your patient for surgery is those who are asymptomatic but the aneurysmal diameter is more than 5.5 centimeters. So remember these two indications. First indication for operative repair, either open repair or endovascular repair, is a symptomatic, rapidly expanding abdominal aortic aneurysm. And the second indication is an asymptomatic abdominal aortic aneurysm, but the size is 5.5 centimeters or more. So this picture shows to us an abdominal aortic aneurysm, which is most commonly located in the infrarenal portion of the abdominal aorta. Let's move on to acute aortic syndromes. So there are 4 acute aortic syndromes. I want you to memorize these 4 acute aortic syndromes. One is aortic rupture. Next is aortic dissection, intramural hematoma, and lastly, penetrating atherosclerotic ulcer. Aortic dissection is caused by a circumferential or less frequently a transverse tear of the tunica intima. So often, it occurs along the right lateral wall of the ascending aorta, and if the dissection is located at the descending thoracic aorta, the dissection is located below the ligamentum arteriosum. The major cause of morbidity and mortality in patients with Marfan syndrome, Loeys-Dietz syndrome, and Ehlers-Danlos syndrome is aortic dissection. They are very prone to aortic dissection. So this picture shows to us what's happening in a patient with aortic dissection. So the dissection is located, it's not shown, but look at the tunica intima. There is dissection and there is a tear. This is the intimal flap, and there is extravasation of blood causing formation or hematoma in the wall of the artery. So others include acute intramural hematoma, which is a result of rupture of the vasa vasorum with hemorrhage into the wall of the aorta. Penetrating atherosclerotic ulcer is also an acute aortic syndrome, which is caused by erosion of a plaque into the aortic media, usually localized, and are not associated with extensive propagation. So aortic dissection is classified based on Stanford classification and based on the Bakey classification. The importance of this classification is the timing of surgery, because type A dissection or dissection involving the ascending aorta necessitates or warrants emergent or urgent surgery. So let's first discuss Stanford classification. For Stanford classification, it is either type A or type B. It's easy to remember. If it's type A, it is always involving the ascending aorta, independent of the site of tear and distal extension. As long as it involves the ascending aorta, whether it started on the ascending aorta or on the descending aorta, this is still classified as a type A dissection. Type A stands for ascending. The second type of Stanford classification is type B dissection. Type B dissection involves the transverse and or the descending aorta without involvement of the ascending aorta. So all type A dissections are sent for surgery. The Bakey classification, on the other hand, is divided into three. Type 1 dissection, which involves ascending to the descending aorta, while type 2 dissection is limited only to the ascending or transverse aorta, and type 3 dissection only involves the descending aorta. So type 1, ascending to descending. Type 2, ascending or transverse aorta only. And type 3, descending aorta only. So aortic dissection, the peak incidence of which is at 60 to 70 years old. On physical examination, the blood pressure may be elevated or decreased depending on the presentation. On palpation, there is loss of pulses, peripheral pulses. On auscultation, there is a diastolic murmur located on the second intercostal space, left parasternal line. Second intercostal space, left parasternal line. This is the murmur of aortic regurgitation. On auscultation of the lungs, you can appreciate crackles, which is suggestive of pulmonary edema. And on neurologic examination, there could be hemiplegia, hemianesthesia, which may be secondary to carotid artery obstruction, or the patient might be paraplegic if there is spinal cord ischemia. Let's proceed with the management of aortic dissection. For medical therapy, almost always, you should always control the blood pressure to a systolic BP of less than 120 mm mercury. Unless hypotension is present, your therapy should be aimed at reducing the cardiac contractility and systemic arterial pressure. Why? Because these two factors can eventually decrease the shear stress. So, you are going to give beta blockers to control the heart rate. The target heart rate for aortic dissection is 60 beats per minute. You should give sodium nitroprusside infusion to control the blood pressure to less than 120 mm mercury. You can also start calcium channel blockers or ACE inhibitors. Remember, direct vasodilator such as hydralazine is contraindicated. The definitive treatment for aortic dissection is an emergent or urgent surgical correction. So for surgery, this involves excision of the intimal flap and obliteration of the false lumen, after which an interposition graft is placed. So for acute ascending aortic dissection and intramural hematomas, Stanford type A, the overall in-hospital mortality rate after surgery is reported to be at 15 to 25%. And the major causes of the perioperative mortality includes post-op myocardial infarction, paraplegia, renal failure, cardiac tamponade, hemorrhage, and sepsis. An endoluminal stent graft may also be used, but this is only indicated for those with complicated type B dissection. Complicated type B dissection is characterized by propagation and compromise of the major aortic branches. There is an impending rupture or there is continuous pain. So surgical correction is indicated for complicated type B dissection if the endovascular repair is not feasible. The long-term prognosis for patients with treated dissection is generally good, with careful follow-up, and the 10-year survival rate is around 60%. Medical therapy is indicated for those with uncomplicated and those with stable distal dissections and intramural hematomas. So type B, Stanford type B. In-hospital mortality rate of type B dissection is approximately 10%, and follow-up at the outpatient is every 6 to 12 months using contrast-enhanced CT or MRI. So remember, every 6 to 12 months follow-up, you should request for CT scan or MRI. CT scan with contrast. That is the follow-up imaging. Let's move on to chronic atherosclerotic occlusive disease. This is caused by atherosclerosis, which is usually confined to the distal abdominal aorta below the renal arteries and may extend to the iliac arteries. It involves the buttocks, the thighs, the calves, And if it is associated with impotence in males, it is referred to as the Lirich syndrome. On physical examination, there is absence of the femoral and other distal pulses bilaterally. On auscultation of the abdomen, you are able to appreciate an audible bruit, especially on the epigastric region and at the common femoral arteries. There is skin atrophy, loss of hair, and coolness of the lower extremities. There may be signs of ischemia. There is rubor or pallor, which can be seen. So, the first picture on your right is when you auscultate the abdominal region. So that is the epigastric area. You will be able to hear a bruit. And the extremities are very cold. And when you palpate for the dorsalis pedis artery, it may be absent. So after the physical examination, you need to request for several non-invasive tests to establish your diagnosis. You can request for leg pressure measurements. You can request for Doppler studies, velocity analysis. You can also request for pulse volume recordings and duplex ultrasound. For catheter-based endovascular or operative treatment, this is reserved for patients with lifestyle-limiting or debilitating symptoms of claudication and those patients with critical limb ischemia. Next is acute aortic occlusion. This almost always results from an occlusive or a saddle embolus that almost always originates from the heart. So this can also occur as a result of an in situ thrombosis in a pre-existing severely narrowed segment of the aorta. So there are two possible causes. One is an occlusive saddle embolus from the heart or an in situ thrombosis in a pre-existing severely narrowed segment of the aorta. On physical examination, you can appreciate severe rest pain. There is coldness, there is pallor of the lower extremities, and bilateral absence of distal pulses. Diagnosis established by requesting an MRI, a CT, an aortography, and the treatment could either be an emergency thrombectomy or revascularization. So next is aortitis. Aortitis refers to the inflammatory diseases of the aorta. It has several causes. So one cause could be TAKAYASU'S arteritis. Others, giant cell arteritis, rheumatic and HLA-B27 associated spondyloarthropathies, and etc., etc. Let's discuss it one by one, the inflammation of the aorta. So for TAKAYASU'S arteritis, it is referred to as the pulseless disease. So what happens in TAKAYASU, this is an inflammatory disease affecting the ascending aorta and the aortic arch, which eventually causes obstruction of the aorta and its major arteries. It may also involve the descending thoracic and the abdominal aorta. It is most prevalent in young females of Asian descent, but it can also occur in other women from other geographic and ethnic origins. It can also be seen in young men. So the pathology for TAKAYASU is panarteritis, which is characterized by mononuclear cells and occasionally giant cells are seen. There is marked intimal hyperplasia, medial and adventitial thickening, and fibrotic occlusion. Manifestation in acute stage, it could be constitutional symptoms such as fever, body malaise, weight loss, And if you request for blood tests, specifically acute phase reactants, you can see an elevated levels of ESR and CRP. On chronic stage, patients manifest with upper extremity claudication, there is cerebral ischemia, and there is syncope. There is no definitive treatment for Takayasu arteritis. However, you can give your patients glucocorticoids and immunosuppressive agents. For those with occlusion, you can offer surgical bypass or an endovascular intervention for patients with critically stenotic artery. Moving on to giant cell arteritis. So this occurs in older individuals. So at this picture, you can see the temporal arteries, which is dilated and tortuous. It usually affects women more than men. It primarily involves the large and the medium-sized arteries. There are important complications for giant cell arteritis. It could be an obstruction of the medium-sized arteries as well as the major branches of the aorta. It might produce aortitis and eventually aortic regurgitation if it involves the aortic valve. The pathology of giant cell arteritis is focal granulomatous lesion. So for Takayasu, it is panarteritis. For giant cell arteritis, it is focal granulomatous lesions, which involves the entire ball. And giant cell arteritis is associated with polymyalgia rheumatica. Treatment is the same. You give high-dose glucocorticoids. This is effective when given at early stages of the disease. So for rheumatic aortitis, the inflammation involves the ascending aorta, which may extend to the sinus of Valsalva and even to the mitral valve leaflets and the adjacent myocardium. What are the clinical manifestations of rheumatic aortitis? It includes aneurysm, aortic regurgitation, and involvement of the cardiac conduction system, which might cause arrhythmia. Idiopathic aortitis is characterized by adventitial and periaortic inflammation with thickening of the aortic wall. This is associated with abdominal aortic aneurysm and idiopathic retroperitoneal fibrosis. It can manifest with constitutional symptoms such as fever and abdominal pain, and treatment involves glucocorticoids and other immunosuppressive agents. For infectious causes of aortitis, it can result from direct invasion of the aortic wall by the bacterial pathogens. Bacterial pathogens such as Staphylococcus, Streptococcus, Salmonella, and can also be caused by fungal infection. So the initial lesion is an obliterative end arteritis of the vasa vasorum in the tunica adventitia. So these bacterial proteases produced by the Staph, Strep, and Salmonella can lead to the degradation of the collagen and ensuing destruction of the aortic walls, leading to the formation of saccular aneurysm that is referred to as the mycotic aneurysm. The pathologic characteristic of the aortic wall consists of acute and chronic inflammation. There are abscesses, there is hemorrhage, and there is necrosis. So there is destruction of the aortic media, which happens as the spirochetes spread into this layer, usually via the lymphatics accompanying the vasa vasorum. So there is destruction of the collagen and elastic tissues, which leads to dilatation of the aorta, scar formation, and eventually calcification. So this mycotic aneurysm usually affects the elderly, more common in men 3 times than women. Manifestations include there's fever, sepsis, which are common manifestations of bacterial infection, and associated with chest pain, back pain, abdominal pain, and if there is diarrhea, usually because of salmonella. If blood cultures are requested, it may turn out positive. So the diagnosis for mycotic aneurysm is by CT and MR. The treatment, because it's a bacterial infection, the mainstay of treatment is antibiotics and surgical removal of the affected part of the aorta. If there is occlusion in the lower extremities, you can perform revascularization and grafts placed in uninfected tissue. Moving on to syphilitic aortitis, this is a late manifestation of fluidic infection. This particularly involves the aortic arch or the descending aorta. Affects sometimes the proximal ascending aorta, particularly the aortic root, which eventually causes aortic dilatation and aneurysmal formation. The aneurysm could either be saccular or fusiform and asymptomatic. However, when there is compression, if the aneurysm is large enough, it causes compression and erosion into its adjacent structures, which results to symptoms and eventually rupture. Diagnosis: when you request for an X-ray, you can appreciate linear calcification of the ascending aorta. Or a positive serologic test confirms the diagnosis, positive RPR and fluorescent treponemal antibody. Treatment for syphilitic aortitis is the same with syphilis. You give the patient penicillin and surgical excision repair. So that's all for the diseases of the aorta. Thank you for listening.